Well, it's a pleasure to be here and to participate in what's really a fabulous, fabulous program. I think the Human Disease Mapping concept is brilliant because it's a very good introduction for me because it really does speak to, let me find my talk, which has disappeared. But I had the pleasure to meet Chris in email and Anakira last night and Helen, and just the way the program is organized, I think, speaks to preparing everyone for the future in the most marvelous way. And I'm a neurologist by training, a clinical neurologist that did postdoctoral work in imaging, and I work across many departments. And so this whole program speaks to how I'd love to see students and scholars trained, and so I'm that much more pleased to be able to talk about our work, and you'll see how this kind of program really interdigitates with my own personal philosophy about how science regarding disease could be optimally done. So I'm going to talk about the theme of major depression and the brain in major depression, and I'm going to use the experience from brain stimulation as a model to realize that maybe we have to really think differently about what depression is, and that'll really influence how we treat it and maybe how we'll cure it. Our work has been mostly supported by foundations in the United States with interest in mental health. The NIH has been less interested in funding this work, believe it or not. We use devices off-label of how they're approved for use by the Food and Drug Administration. And so everything I'll talk about is highly regulated, highly managed. We've developed a patent for this that has been licensed and is the basis for actually a clinical trial. So again, it's how does science lead to ways in which you can actually take it to the next step to potentially help more people than just your research group. So the thing I want to start with is have you appreciate the role of students and actually the role of a very, very multidisciplinary team. This started in Toronto. I basically went to a neurosurgeon and asked him if he could put a wire in some patient's brain, if he actually thought that was safe. I had some psychiatrists that were involved with me on other projects, at Kennedy, the second from the left. And Clement Hamani, who has now become quite a scholar himself, was a junior neurosurgeon that just became interested by the access to doing the cases with his mentor, Dr. Lozano, and now runs a whole animal lab on this topic. When I moved to Emory, I needed to engage a whole other new team to continue. So I have a new neurosurgeon, a new set of psychiatrists, and we have everything from senior level psychiatrists to trainees in the residency program. I've got 3 students that are either in biomedical engineering or neuroscience that work on various aspects of imaging and are involved in these projects. Electrophysiologists, both that are graduate students in BME or postdocs in biomedical engineering, people who work in animal models and neuroscience, people in psychology who do cognitive neuroscience and have added their expertise to the project, psychotherapists, and biostatisticians, and then obviously, staff that actually has to be trained and learn from this herding cats team to actually integrate with everyone. So you can kind of see that the work I'm going to describe is going to involve many people at different points in time, and we kind of figure it out together. So what's the problem that we're addressing in this work? Well, in major depression, the good news is that we have lots of treatments, and a lot of them work. That's why they're called evidence-based treatments, and they're available. The problem is they don't always work. And unfortunately, the numbers are that we only get people well in an episode of major depression about 40% of the time, which is pretty lousy. I mean, if you had high blood pressure or an infection and you only had a 40% response rate with the first treatment you tried, you wouldn't think you were doing a very good job. And infections kill people, but depression kills people because they kill themselves, and they don't work. And our big problem is we don't have biomarkers that help us to know what is the right treatment for a given patient. and worse, that if you get well, pretty much guaranteed you're going to relapse. Because recurrences are common, it's a recurrent disorder. And so fundamentally, you have to get people out of episodes, just like if you have diabetes, people aren't always in the hospital in diabetic coma, or if they have an immune problem, multiple sclerosis, you have flares and episodes. But depression has that same chronicity with episodes. So the biggest problem is about 10% of people become what we call treatment resistant, which means that they got better before, and now when they have an episode, what worked before doesn't work again, and you use progressively more aggressive treatments. And once you reach a point of using electroconvulsive therapy, which is an exceedingly good treatment, when you fail that, you pretty much are out of options. There's a lot of research on a lot of other kinds of interventions. They're usually not done in people who are that ill. So if you reach that point, the question is, what do you do? Well, it tends to happen kind of on the street is people keep going back for more shock treatment, which is blasting your hippocampus, giving you problems with memory. You may get out for a while, but you seem to click back in. So we're fundamentally missing something about the biology. So I want you to kind of have that as the context, because I'm going to be talking about actually opening up somebody's brain and putting a wire in it to basically put a pacemaker in their brain. And the idea that you would even do that is sort of rash, but the context is, what was the context at the time that we started to think about that? And I think the exercise for today is to kind of put yourself, I'll try to put you all in our situation. What were we doing? Why would we try that? And to kind of realize that many times being in the right place at the right time, but more importantly, knowing you're there is the key, both having a good time as a scientist, but also doing something that might potentially make a difference. So our thinking back in 2001, why would we even entertain this thought? Well, around that time, we were doing all kinds of interesting things with imaging. And in 2001, not quite before you were born, but I will show you data before some of you were born, which is really horrid to think about, but that the advances in structural and functional neuroimaging was really just starting to really change the trajectory and really have an upslope. fMRI was really in its early days. Diffusion imaging really wasn't in the mainstream at all. PET scanning with metabolic and blood flow imaging was really the foundation. The other critical key was stereotactic neurosurgery. It's really becoming quite advanced, and I'll show you in a minute why. And most critically is, nothing's ever fundamentally new. It's kind of knowing how to leverage something else that's happening in another field. And again, that's what I think is so brilliant about this whole program, is the exposure to people totally outside of your field of view to kind of think about possibilities and to leverage someone else's methods that are not necessarily your methods. So what is the prototype in Parkinson's? It's a disorder that has mostly tremor, rigidity, slowed movement, but also problems with autonomic function. People have trouble with blood pressure, temperature control. They have mood dysregulation. They become demented, have trouble with frontal functioning. But that the core syndrome is a motor syndrome. The good news was when they cut the brains, they saw that the brains were very abnormal. They had loss of pigmented nuclei in the nigra. With time, it was come to understood with basic work that those cells made dopamine. So there was loss of dopamine in the major core regions, that one could map the dopamine abnormality and see that not only was it abnormal in the midbrain, but also in projections to the striatum. But what really started to help, because this was really a basis for how L-DOPA, giving dopamine precursor, you could make dopamine if you still had cells. It became then that when you could no longer make your own dopamine, you could give a dopamine agonist and go at the postsynaptic site. But it was really then taking that knowledge and saying, well, what's the relationship between the midbrain and the striatum? What's the circuit? What's the the structures in which dopamine is acting. And then a whole parallel set of physiology experiments were really trying to map out how does dopamine influence cell firing, which cells, what's the interaction between dopamine and acetylcholine, and you start to define a set of motor control circuits. And it was in that context that actually people could understand a surgery that had been done for 50 previous years, where you could make a small ablative lesion in the thalamus and stop tremor. You didn't have to have dopamine, didn't have to know anything about it. I mean, they were making lesions in the thalamus with crude stereotactic devices for many years. And a clever neurosurgeon in France, Louis Benabide, basically while he would be going to the thalamus, would do high frequency stimulation, recording and high frequency stimulation. So he knew the characteristics of the thalamic cells. He knew that if he interrupted them with high frequency stimulation temporarily, he could stop the tremor, know he was in the right place. And so they set up this amazing 24-hour experiment where they decided they would rig a stimulator from the spine that was used for pain to hook it up to, instead of making the lesion, set up to deliver high-frequency stimulation all the time, and actually saw that then they had a reversible form of stimulation to turn off tremor and didn't need to make the lesion at all. And this just gives you an idea of what that's like, because when you, here's a woman with Parkinson's disease who's had an implant in the subthalamic nucleus, which is now an approved procedure. It's been done 100,000 times, at least with devices sold for Parkinson's disease. And here's what happens.
Are you able to touch my finger?
Not with the right inside.
Okay.
I can't.
Can you try to touch my finger? That side's a little better.
That side is better, yeah.
Very good.
So it's turning it on.
Just turn it on.
Immediate. So you see the remarkable thing that knowing where to do something can do immediately, and that was the context. So can we treat depression like Parkinson's disease? Well, we've got a syndrome. They've got a syndrome. We've got a syndrome. It's mostly a mood disorder, but then it's negative mood, lack of positive mood, lack of interest, sort of fuzzy. Is it too little positive, too much negative? You might want to model that differently. You have problems with cognition, like Parkinson's. It's attention, it's short-term memory, it's executive function, a lot of things similar to Parkinson's. It affects circadian rhythms, vegetative functions. People have trouble with sleep, appetite, libido, energy, all part of the definition. And there's a motor component like Parkinson's, except not as dominant. People can be quite agitated, move around, can't hold still, or they can become so profoundly slow they actually look Parkinsonian. It's a diagnosis made by self-report. That's a problem. A physician can look and make observations about behavior. It's very easy to tell when someone's depressed. You all know somebody who's depressed. You can see them coming. You can't even force your own facial expression to adopt what happens to your corrugator and zygomatic muscles, which is an interesting clue. There are clinical features that you can have checklists about, and there are biomarkers. The hypothalamic pituitary axis can be quite dysregulated. There are changes in BDNF, autonomic functioning, heart rate variability, temperature regulation, like I said, facial expression. The psychologists study negative bias in terms of negative cognitions. It's almost like you're looking for something bad magnet. The whole world seems to apply to you if it's negative. And like I said, some of these cognitive elements, but there's no pathology. So again, we have a problem starting out. We don't have the luxury of knowing there's an abnormality and build up from that. The treatments, a lot of them, they are all pharmacologically based. They wrap around monoamines. And why monoamines? Because by some accident, someone was manipulating blood pressure and saw someone get depressed or had depression change. And it wasn't until the development of fluoxetine, Prozac, that actually a drug was made to specifically target the serotonin reuptake site. But It affects serotonin, norepinephrine, dopamine. But if you deplete any of those neurotransmitters directly, you don't actually ensure inducing depression. Now people are looking at NMDA with ketamine, at acetylcholine with scopolamine, even buprenorphine to look at the opiate system, psychotherapy, ECT, even making lesions in the brain, lesions in the orbital frontal cortex and the thalamic outflow along the cingulum bundle. I mean, these were done for, Moniz won the Nobel Prize in 1937 for orbital undercutting. So there's something that so parallels what I showed you in Parkinson's that anyone studying, so you can understand me as a neurologist wanting to study a psychiatric disease. I started with Parkinson's. Because look, if Parkinson's doesn't have a signal with depression, no way am I going to mess around with psychiatrists and their fuzzy way of thinking to look at a psychiatric disorder. I'll hide out with a neurologist for a while longer and see. And so there was logic even at that time, again, coming from the movement disorder, thinking about cortical basal ganglia loops. But even then, there were clues that Suzanne Haber published where it wasn't just that parts of frontal cortex were projecting to different parts of the striatum in just segregated, stay-in-your-lane pathways. But Suzanne started to really see that by the time you got into the striatum and into the main brain, you started to have intermingling of these fiber bundles. So you had places where affect and drives could influence thinking, where thinking could influence movement, and start to actually think about models. And I'm not saying anybody wanted to think about it that way, but what I'll tell you is when you came at it from the fuzzy part, from the clinician's point of view and the patient point of view, you had to take advantage of that kind of logic because there was no other way to explain what you were seeing. So where we have to go from here to get to putting a wire in someone's brain is, what are the necessary circuits, pathways, and nodes in patients who have depression? If we're ever going to think about we're going to tune something, where are we going to tune? So what are the steps? Well, the question then was to use imaging to kind of build the model now using the patient as the model system and then use the tools that were available. In the early days, this was like take natural lesions. People have strokes. People after strokes develop depression. Bob Robinson in psychiatry with colleagues in neurology would look systematically at depressed patients after stroke and say, where's the damage? And started to notice there was a predilection in the left frontal cortex, but not exclusively. People started to look at MRI measurements and started to see that with whole brain measures, just let the brains tell you where they're atrophic. And Wayne Drevitz noticed, and then it was verified in postmortem brain, that the ventral medial frontal cortex seemed to be small, and that the kinds of cells that were small, were atrophic, were glial cells. And a different line of reasoning coming from the stress literature was that with stress, you saw shrinkage in the hippocampus. And what became clear in animal models was that there was shrinking of dendritic spines. And so there started to be a set of nodes that you could see structurally, but the caveat was if so damage someone's, an animal's frontal lobe, do you make them depressed? No. Remove a hippocampus, you don't get depressed, you get amnestic. So again, what is causal, what is correlative? You have the same problem that everyone always lobs at clinical research, cause and effect. You don't get to create the problem and watch what happens like you can in an animal model. But in patients, you have the opportunity with functional imaging to study people when they're sick and then do a causal intervention, change them by treating them and getting them well. And at baseline, we started to see that, and these are glucose metabolic PET scans, again, ancient history, but you can see our interest because we were replicating in Parkinson's disease or Huntington's disease or stroke or Alzheimer's, the same pattern if you looked at depressed versus non-depressed patients. It looked like unipolar, it looked like bipolar. Other people were studying this in our hands. We were getting these similar patterns. And we were starting to get candidate nodes to start to build a circuit. So then the obvious thing is, well, how can you refine down which was our important, what's the causal relationship to the symptoms? We'll take people and treat them. and use treatments that you know that work. And we started with medication and serotonin reuptake inhibitors. So we had a set of regions that we could start to organize by correlative interactions with different behaviors, a very common line of reasoning in cognitive neuroscience. But if we then did FDG PET scans in people before treatment and after treatment and looked at what did successful treatment do to the brain, we started to see some patterns. So with drugs and with different drugs, we saw that abnormally low metabolism in the frontal lobe normalized. And here in blue are areas that decrease the metabolism, and they tended to be characteristically in limbic and paralimbic areas. We started to see this funny region that we knew nothing about on Brodmann area 25, the subcallosal cingulate. We were seeing changes in the ventral anterior insula. We're seeing changes in brainstem and striatum. All these same areas were starting to show up, but there seemed to be a common pattern of limbic going down, cortex correcting, and there are actually changes with treatment that we didn't even know we should be caring about because they weren't abnormal at baseline. We said, okay, drugs are good, but people get better with therapy. Does therapy work in the same place that drugs work? And it turns out works in the same place, but not exactly, and doesn't necessarily do the same thing to the brain. So the real estate became more important, the nuances became more important. And our interpretation at the time is that you had very complementary ways in which different treatments might be synergizing to make people better. And, that was really good. It's like the United Nations with all the treating people, because the therapists are always in conflict with the psychopharmacologists, as though, why can't we all live together in peace and love and harmony? But, everyone's kind of who gets market share. And then patients have biases. I want drug. I don't want drug. I want therapy. No, I'm not talking to anybody. I don't have time. And the issue is that they are complementary for many people, but you can imagine you have to get the right treatment to the right person, and that's for another discussion. But it turns out that the brain pattern that you have can actually predict what treatment actually might be best for you. So one size doesn't fit all, sorry. But the issue, for back to the question at hand today, is what node, which pathway, which place. It's a big real estate. This is like nodes in the whole brain. It's great if you're doing path analysis, graph theory, structural equation modeling. You're a computational person, have a field day. But if you're trying to put one wire in one place, the point is you don't know where to go yet. So then the real question is what do you really want to do? Think back to the Parkinson's story. Lots of different pieces to the syndrome. When you're in the subthalamic nucleus, you get tremor and rigidity, slowness. People still fall. You do nothing about their mood. You drop their medication, they get even slower. They're not even particularly happy about their thinking because they were getting a lot of bang for the high dose dopamine that they were getting. Makes them think faster. Same thing in depression. It's this syndrome. Everybody's always complaining about no two depressed people look alike. The diagnostic criteria let you have combination of symptoms, so different people don't even have the same combination of symptoms to meet the criteria for the illness. There must be all these causes. We can never solve this. Let me go study epilepsy. It's too hard. If you really kind of listen back to the patient, why do people kill themselves? Because they can't stand the pain. Can I just have a rest for 1 second? And you look historically, whether it's William James, William Styron, one of our famous patients in Toronto, what does a patient say if you listen to their words? It's agony, it's anguish, it's psychic pain. It's psychic pain to the point that I cannot move. So I talked about movement. Movement doesn't happen and then you feel bad about it. Most people who are paralyzed don't have psychic pain. They're unhappy that they fell, that their life has changed. You have a reactive change in mood. The mood is not the driver. What does this patient say? A gnawing agony, painful, to the point that he hates himself. How can you hate yourself because you actually are in pain? That is totally ridiculous when you actually think about what they say. What is guilt? Being guilty about something you didn't do. That consumes all your energy and all your attention. Think about when you have something very bad happen to you. You are momentarily offline. You see something really sad in the news, you don't really kick back in to present until the phone rings or the story changes or they show some person with their pet and they break the mood for you in the report. So the question is, I would argue that the problem in depression is primarily a negative mood. Get rid of that, everything else is derivative. And again, that's a hypothesis, not popular, but to me seems incredibly obvious. And the question is, can you prove that? And that everything else is derivative. So let's start by mapping where negative mood lives, and maybe that gives us a clue to a node. And so we did an experiment way back, and this is actually the hardest paper I ever got published. It's the most cited, like 1,300 times now. So it just shows you, got to be perseverant. This paper, everyone wanted it to be broken up, but this paper did two things. It looked at the pattern of change with treatment, where we saw cortex up, limbic down, and we wanted to know where the sad part was. So we took a group of healthy people and we made them sad. And we said, think about a personal sad memory, lie on the table, use the personal event to remember how you felt. We want a picture of thinking about the event. We want you to feel bad. And so we actually waited until people reached 7 out of 10 on an analog scale. Everyone was actually tearful. If you don't bother people and you let them emote, and on a PET scanner, there's no noise. You don't have that banging sound like MR. Because as soon as you are aware of your own emotion, you'll turn it off if you're healthy. You actually see that the area of the brain that activates more than anything else was this area 25, and you turn the frontal lobes off. And we actually got the exact mirror of a set of regions that we saw with the treatment recovery. And so we started to kind of hone in. And so if we now kind of say, okay, we've got big area of frontal cortex, and when you think about people put magnets on frontal cortex to try to up the activity with transcranial magnetic stimulation, or can you drive down the activity in area 25? Area 25 lights up if you deplete serotonin in vulnerable people with a tryptophan depletion. And it turns out that downregulation of 25 is seen across 3 experiments we've done with serotonin reuptake inhibitors, with venlafaxine, a combined serotonin norepinephrine reuptake inhibitors. You even see it downregulated in people who get better with placebo drug. It turns down with TMS applied to prefrontal cortex with a generalized seizure after recovery with ECT, going peripherally through the vagus nerve. Basically, you need to downregulate this region. And it turns out this is pretty much in the vicinity where the low glia are in the postmortem brain. So our idea was treatment resistance is failure to modulate this area, so maybe you just ought to help it directly. And so that's what we did. We had this multi-node model. We knew that from tract tracing studies in Suzanne Haber, Petrides, there are many people who have mapped out the connections in non-human primates, that, this is a drawing, I found it on the internet, of my own trying to explain it to a reporter who kept the napkin, and it ended up online. And just as a funny aside, last week I get this email from this musician in Nashville who has named her band Area 25. Because her husband, the drummer, is a psychiatric nurse, and they decided that Area 25 spoke to them as, thoughtful, introspective indie band, and that she wanted to use, she had found this picture. It was, you've arrived when your scribbling in the trash makes it to someone's album cover. But you can see, thinking where the 4 contexts are is at an intersection of a set of connections to get into the very regions and behaviors that make up the syndrome. And so basically, with the neurosurgeon, can you place it safely in that approximate location? And at the time, we didn't know exactly where. We just kind of knew there was this blob. We could kind of get there. We knew the anatomical location. And with stereotactic guidance, we could place the electrode there. We had 4 contacts so that we had some anatomical range. And here you can see an MRI. Here's in proportion the electrodes. There are 4 contacts on the end of the electrode. The electrode's about the size of angel hair pasta. So it's very, well, anything in your brain is not small, obviously, but it's actually, relatively speaking, small. And it can be placed with exquisite precision under this MRI guidance with a person in a frame and awake. You can place it, and then a battery, pacemaker, it's called an implantable pulse generator, has a little computer, and you can set and adjust the parameters that you want externally. So this is what we're going to do, and I want you to listen to what a set of patients actually had to say. Like, what was the part of their depression that they thought that was disabling?
It's like a stickiness. It kind of holds me down, and it takes so much effort to do anything.
She's saying it's heavy. Like a paralysis. She's kind of quiet. Can you hear that? Can you hear it?
I look in the mirror and see the person that I know as me, feeling like I've lost me, to be numb to feelings.
It was kind of like sliding down into the bottom of a well. It's very, very dark. There's no one there. There's really no light.
I was pretty convinced that I was going to die, that there was nothing left for me. My life had completely closed in. I had no friends. All I did was lay in bed for days. Sometimes I'd sleep, sometimes I wouldn't.
So it gives you a flavor, when you just look at a list of symptoms, what's that like for somebody? And I don't have depression, so I don't know what it's like, so you can try to channel what you hear. But I think when you hear it from a person's own mouth, those are people being interviewed, being interviewed prior to, day or two before surgery. What is it that you see? You see their facial expression. You kind of see this pained look. And, they're not, each one of them will tell you how it impacts their family, how it impacts their work, it impacts, a whole network of people and things. But at the end of the day, there's this feeling, and I can't make it stop. And it's irrational, and what can I do? And the reason I'm kind of harping on that, particularly for people who are in the lab, is that if you just look at that or listen to patients, you kind of go, that's not modelable. I don't think there's an animal model. I haven't found one yet where animals will actually kill themselves to escape something. Can you create a model that creates that? So we may not be able to model that, nor would animal review boards allow you to do that. But it's very important to at least have it in your mind when you're setting up a model and an animal doesn't want to take sugar, is that actually getting at the core problem? And you can have model animals for elements of these circuits, but to always keep in mind, which is what we have to do, sometimes the human work allows you to do things that you can only do in people. And it's the complementariness of the work that we want to think about. So here we are in the operating room. I'll show you this nice tape that CNN put together so you can appreciate what is going on. So just imagine that we go to do this the first time. This is not the first person. But we're doing this, and what you're seeing happen to this lady, Edie, was happening for the first time when all I knew that when we did this the first time is just, please, can nothing go wrong? With the knowledge that you have an off switch. And with the surgeon, with the collaborative nature, I'm risk avoidance. So this would not be something that, might be my idea, might be in theory what you want to do, but when it comes down to we're going to go in someone's brain, it's like to satisfy my scientific curiosity, nothing better go wrong. And so it made it that much sweeter to have it go well when all you could do was really worry about what the worst case scenario would be. So here we go. You are there.
You could see it happen when she was wide awake in the operating room with Doctors Paul Holtzheimer and Helen Mayberg.
Are you okay, Edie? Okay.
As a benchmark, they asked Edie to rate her feelings on a scale of 1 to 10, starting with dread.
Your sense of dread is getting worse. Rate it.
2 minutes later, they turned on one of the 4 contacts.
How does it feel right now? Is it still hot? What's the dread right now?
A drop from 8 to 3. But doctors would soon get an even better result.
Like they're going to make some changes.
Remember, before the surgery, Edie could not connect emotionally with her grandniece, Susan. Then, they turned on contact number 2.
Just let me know if anything changes, just give a shout. You just almost smiled? Look, describe that for us, would you please?
It brings tears to your eyes to see somebody that's in such pain, and then that goes away.
When you say you almost smiled, did something strike you as funny, or is it just sort of spontaneous?
It was, well, I think actually Dad was thinking of playing with Susan.
So again, I mean, there's a subtlety to it. It doesn't push happy. It sort of takes a negative away that becomes such a surprise that is interesting. And this kind of lifting, kind of feeling lighter, feeling relief, feeling, the first patient just suddenly said, I don't know what you just did, but I suddenly feel calm. And it's always it's always metaphorical, that the sensation is not like I touch you in motor cortex or sensory cortex and you know precisely within millimeters of where you've touched. So there's this visceral state that all the patients describe. That was kind of juxtaposed. The patient didn't actually know when we were turning it on or off. We filmed the surgery with everyone there, but the clip of her was without the background noise. That was a tape we had done, and they spliced 2 cases together just for knowing, because the first thing you'd think is, oh, well, you just led the patient there. They knew what to expect, and we're actually pretty careful about that. So that's all fine and good, something kind of dramatic in the operating room, entertainment value for the team, or is it actually useful? Because you can have side effects that maybe are very profound behaviorally, but might not be useful for anything. And so what was important was leave the operating room, put the setting on, and then trial and error to see what happened by doing stimulation at that location over time, and see what happened both for safety and what happened at some arbitrary endpoint, which for us was at 6 months. And we operated on 6 initial subjects, all profoundly ill, on average 5 years in their episode, having failed that group, I think 17 different combinations of medicines. People had been in asylums, having gotten repeated ECT. It was barbaric what had happened to many of these people. And what we had at the end of 6 months, open label, so no blinding, 4 out of the 6 of them were well. And better for scientists was they had overactive subcallosal cingulate at baseline that had downregulated with a stim even at 3 months. But more interesting, and I think what turned out to be much more important, was we saw changes that were outside where we stimulated, that we were getting into the more distributed circuit, and that was important. So what we saw, and there's now been a number of studies. So the team in Toronto went from 6 subjects to 20 in that first group, and this is the outcome. Here's the Hamilton severity score, minimum over 20. Dropping by half is considered a response. You can see as a group, it dropped down by about 2 months and stayed down. We had a 60% response rate. And the long-term follow-up on the patients that continue out, at this point, this publication was out to 6 years. If you got well, you stayed well, as long as the device was on. Didn't make changes once you had the right setting, the right place, set it and forget it. At Emory, we did a study with a placebo first month period. We did bipolar as well as unipolar patients who all were kind of stuck ill for that minimum period of time. Got a similar curve to what we saw in Toronto. We didn't do quite as well. We had a 42% response rate at 6 months, but by 2 years we had a 90% response rate. And in the entire group now, we have an 80% sustained response rate going out. Our first case was in January of 2007. We don't change the meds in the first 6 months so that we know that the effect we're seeing is due to the brain stimulation. And as long as it's on, they stay well. If the battery is depleted, a wire breaks, they'll lose the effect over several weeks. So whatever we're doing, even now, 5-10 years later, we're not fixing it. It's not like putting a cast on a broken bone. Whatever plasticity is happening, which is definitely happening, people will describe 2 years after implant, they say they continue to feel better than they did. Even, they haven't had a relapse in that time, but they seem to be able to take on, they're more resilient, they take on more activities, they just seem to get stronger and stronger. But, that's kind of normal life. You're more competent 2 years after you learn something than you were 6 months after you learned something. So I think they're just expressing how you kind of just become better at better, whatever it is that you're doing, that we all, if you're not ill, just take for granted. So this gives you an idea, outside the operating room. This was our very, very first case. This is a day after surgery. This is a woman that described a lightness, a heaviness, the heaviness was gone. She has her electrodes externalized, and you're going to watch the contact that worked in the operating room, what happens when you turn it on again, just in the lab. And we're sitting with 4 extremely tired neurosurgery residents who've been on call, who've been dragged into this little room to watch, most of whom weren't there, aren't interested. And so what she's saying will resonate in that context. Hold on. Oh, sorry, I did it again. I didn't turn it off.
And that cessation of joy.
Look at her face.
You're still in that hole, you think?
I feel that way. I don't feel,
Even kind of there's like a word finding problem. Whatever this is, it's not cortical. It's very hard to describe. It's a black hole. People describe being in pits. What are you talking about? You feel paralyzed. You can move, but you can't move. So again, the metaphorical nature of it does not lend itself to neuroscience, but it's as plain as the nose on your face when you see it. So here she is, 10 seconds later, and turn it on.
well, I feel calm and harmony. I'm feeling like I want to smile or laugh or joke around. I'm looking at everybody's expressions on their faces.
Mouse open.
Feel more in tune with the group? Yeah, more in tune with the group, looking at everybody's expressions and
So again, this kind of instantaneous, a little context, but again, you go from a brake being on in the car, you can move if the brake is off. You can't move if the brake is on. There's this immediacy that's interesting and important, necessary but not totally sufficient, because here's what you see by 2 months, what patients are describing.
It gave me the break. It gave me the energy. It gave me the release from the oppression. It made things a little bit easier.
It sort of took away the pulling of the depression, the
emptiness, despair. I'm glad that I don't have to worry about it.
You're just getting on with life.
Yeah.
That I learned in cognitive therapy, when something made sense, it made sense up here, but it made sense in my soul. Night and day what I got out of cognitive therapy before surgery and what I got out of it, because I had a brain that worked.
So, I mean, the patients kind of explain that this lifting, even though they metaphorically may describe positive, there's something very positive when negative is turned off that's different from, taking speed. And that making that differential in terms of models, I think, is very important for the next step. So anyway, so now you kind of know what it's like. Other targets in the brain are being studied because, we've got a whole network. People are going at enhancing positive, looking at the absence of reward, going into the monoaminergic system, going at the medial forebrain bundle, going at the nucleus accumbens. And again, the data will tell over time. Patients are doing well, out to 6 months a year. And the question is are we just getting at different nodes in the same system? Do certain patients may do better to enhance positive or enhance drive over turning off negative? I think that time will tell as we kind of study this more. So now we get into, even though I've used a lot of time, into what the really salient scientific questions are. Because once it actually works, then the real fun part comes, or the hard part comes, is what did we actually do? And so we've got to pick patients. 60% in people this ill is really bragging rights if it can be replicated. But now everyone wants to know, well, who are the right ones? So you actually really are back to what we need for deciding to get drug or therapy. Now you really need to know who are the right people to operate on. So you need to have enough non-responders to know how to avoid other people who are like them. Can we do better with the surgery? It's still a big territory, even though it's fairly refined. Can we get people better faster? Maybe if we got everybody into therapy fast, you could push them faster. And it turns out that therapy is helpful, but whatever goes on to reintegrate into society when you haven't done anything for 10 years doesn't seem to get any faster by talking to a therapist. But the therapists tell us they don't actually do conventional therapy to help them with negative cognitions. They don't have those anymore. So they're actually working on life skills, not on classical cognitive therapy, retraining of negative biases, which is interesting in and of itself. I think mechanistically, there's that immediate effect and there's chronic effects. Why does you not make the numbers for about 2 months? And in some people, not until considerably later. What makes a slow responder over a fast responder? Is it how much atrophy they have in their hippocampus? I mean, does it just take longer to learn because the rest of the system has to have time to kind of recalibrate as well? Does it impact all the clinical dimensions equally? Think of the Parkinson's. And you can start to see, how do you reverse engineer that? So anybody who wants to know, the best anatomical evidence at area 25 is infralimbic cortex in a rodent. It projects down to the same brainstem striatal systems. And again, live long enough, you have the last laugh. Everybody that I ever talked to that did rodent work, when I would beg them to do their experiments on infralimbic, pre-2005, couldn't be bothered and would blow me off if I went to talk to them at a meeting. Those are the same people who called when the neuron paper came out and wanted to know where area 25 is. So you've got to be tough-skinned, you've got to be a little rejection insensitive, because in the end, when everybody else can kind of see how it might apply to their work, then everybody kind of joins in. And I think that being able to do that on the front side is what we try to do, but you don't always know, and it's a free world of what questions you pick to do. But everybody wants to direct their own experiments to something that will really interdigitate with something that has real-world implications. So the obvious thing is to think about sources of variability. And so the obvious thing is, do you blame it on the psychiatrist? Do you blame it on the surgeon? Who didn't do their job right? Patient selection or implantation? It's much easier to kind of blame the surgeon or to work with the surgeon, because the surgeon can probably make strategic changes differently than the psychiatrist can. And if you look in standardized anatomical space and say, where were we stimulating at 6 months between responders and non-responders? The bad news is that surgeons do a really good job of putting it in the same place, at least at the level of anatomical resolution, of location of standard brain. So the imagers know what I mean. You can warp the brain and say precisely the coordinate in standard space. Where are we? You can see responders and non-responders. They're virtually identical. You cannot tell them apart. But we had a clue in the early days. We didn't make a big deal about non-responders in that first study because there were only a couple of them, so we didn't trust the stats. But if you look at what happened to non-responders over 6 months, well, area 25 turned down. We didn't miss there. What we missed was having impact on the rest of the network. So the question is we know there's a rest of a network. At the time, we didn't have tools. We didn't have tractography. We didn't have a way. We made inferences about the tracts because we could kind of, you can kind of see the white matter tracts. You can kind of get an idea of where they are from the structural anatomy. But now we've got the ability to look at all of the fibers. And the question is which one of this big jumble is actually relevant? Well, you can start to, in individuals, take each of the contacts on the electrode, do a region of interest, ask a question of the tractography map and say, where are you connected to in the white matter between contact 2 and contact 3? Because contact 2 can give you that lifting effect and contact 3 doesn't. How can it be so close and make such a huge difference? Doesn't seem possible. Well, because look what we have here. This is one person, probabilistic tractography. You can see the difference in the tracts. So what we did is we engaged a computational engineer, a biomedical engineer who does modeling, Cameron McIntyre, and his graduate student. And they actually have worked out a method for modeling the tissue activated based on how much you're stimulating, where you are, where the white matter fibers are relative to gray matter. And you can actually model a new region of interest to apply to the tract maps. And we asked a very simple question. If you were better at 6 months, you and everybody else better at 6 months better have something that you share in common. So we will do a tract map on everyone. We will look at every voxel in the brain. You either got there on your tract map or you didn't. So it's a binary, not how strong, because no one really knows how to model the strength. Yes or no. Everybody had to have a voxel or you weren't in this map. So if you were well, this is the map of response. If you were not well, here's what's shared, with the caveat that a non-responder could be missing something differently. But this is what they all had, and you say, well, boy, that's pretty close. Cingulin bundle down to the midbrain. But if you start to look at the difference, and here's some help from the overlap map, you can see that they share most of the map, but they're missing mostly the connections to medial frontal cortex. And if you look at the people who were better at 2 years, with many people having had the contacts changed, you start to see that that was very important. And in fact, if you look at the people who had a contact change between 6 months and 2 years and didn't look at anything else that might have changed for them, you can actually see the green is what's shared, and the blue is you can see that where we tend to miss is getting into the overlap of where those particular crossing fibers are. And if then you get into the details of the actual bundles, you see that we're at a confluence between the cingulin bundle, which continues down to the midbrain, the uncinate fascicula is coming from the amygdala, the lateral branch joins the medial branch, hits 25 and talks again to medial frontal cortex, and sits just below the corpus callosum fibers, forceps minor, that connect the two hemispheres. So you actually, if you're a little too far Posterior, you miss forceps minor, the one that we would tend to miss the most because we didn't appreciate the confluence of these 3 fiber bundles. And now you can look at this in exquisite detail with these really new wave scanning devices. But even sitting on a laptop with deterministic tractography, we can sit and drive around in the operating room before we start and find the spot where we get the confluence of the locations, and we tell the surgeon to put contact 2 right there. And then we can test that. And we've done this now prospectively, 11 cases, and we can predict when they wake up, predictably by doing that. So I want to go past this to kind of make the point that we now are in a position to actually ask some more questions about what is the nature of these different connections, which one of these bundles might be primary relative to secondary. And you go back to the literature, some of the things are our work, a lot of this are papers that we wrote that was just trying to look at, in healthy people, at the nature of self-referential processing. What's it mean when that lady on the table thinks she's thinking about her granddaughter? The connectedness to a child. Women all describe that that is the worst part. That woman would try to hold that baby thinking it would make her feel better, and it was like the baby was, it didn't feel right. It was such a disconnected sense that she would have to put the child down. So she was thinking about that when they turned that stimulator on, and she felt that sudden connection. That self-reference, that emotional connected area, people study it in schizophrenia, theory of mind, empathy. That part in medial 10 is that element, and that is a real core part of this syndrome. And it's the fuzzy part, but it's the most human part. And again, you know, if it was easy, we'd be done already. Medial 10 is not a region that rodents have. And that is a part of this that you cannot study in lower animals. You probably could study it in non-human primates. They do have that region. I don't know how you would ask them, but you have that. So we want to use these now for biomarkers of the pathways. We don't want to be dependent on metaphor listening, although it's really fun and everyone likes coming to the operating room. But if you could have a biomarker as a surrogate of that, it'd be a lot easier. So we went back, took all of these metaphors and said, let's see if we stimulate and we can predict where we're going to be in the operating room, which contact is going to evoke one of these things. What can we do to actually measure the physiology while it's happening? We didn't know we would get so good at the tractography to predict it. But in fact, we said, well, we'll have some people who have these self-reports. We'll be monitoring what's happening to them. And then when it happens, we'll capture it, and then we'll be able to look for it in people who don't say it. And so now what we do is this elaborate experiment with everybody in the operating room, plan the tractography to do the surgery, do EEG the best we can on the part of the scalp that isn't scrubbed, which is mostly just the frontal lobe. We have the bilateral implants. We put them both in and don't test them one at a time. We get them both in. So we have all 8 contacts to test. Everything's wired up, including skin conductance and heart rate. And we can literally go on and off in a blinded way at those contacts. So I have no idea which one is the one that we actually picked. And we have gotten 11 for 11 to predict that when we've stimulated the place that we're in, that we get a behavioral effect, we get a skin conductance effect that happens immediately when we turn it on, and a heart rate effect, so that an effective contact, both at skin conductance and heart rate, is seen not with an ineffective or a sham stimulation. So we've used the phenomenology to go back to do a rigorous experiment, to measure physiology, and actually are finding that these autonomic effects are all mediated by the cingulum bundle, which goes with work by Hugo Critchley, showing that the mid-cingulate actually tracks with heart rate and blood pressure and autonomic effects when you're doing hard cognitive tasks. We can even show Area 25 pictures, emotional pictures, and just listen to what the cells are responding to. And these cells, and this was a study just came out from our work in Toronto, tends to respond to negative things, not positive things. It may be that it's biased, because if it's exhilarating, they respond, but not as much. And now we're in position with chronic recording to actually see if we can change the bias when we stimulate. So maybe the cells are more responsive to other things. So our goal is that we do fMRI, and in fact, fMRI in these tracts to medial frontal, we downregulate the PET. It's disconnected with seed functional connectivity. It's offline. We change the connectivity over time when we get into the tracts that affect that area. We get the behavioral effect, and if we stimulate there, they get well. And now we have a prototype device where we can make these field potential measurements off of area 25 in real time, both in the operating room, and here's very early work by our graduate student in the off position. This is phase amplitude coupling. You can see the pattern here. You turn it on and you get this low frequency coupling of delta to gamma, that when you turn it off, it actually persists. We'll now be able to look at these kinds of signals recorded chronically outside of the operating room and know what we have. And you can start to imagine how to use optogenetics, how to use tools where you could make measurements throughout the brains in animals to kind of work back and forth between the human and the animal model to really refine what's happening. So to just finish, we've got, what are we really doing? And, what's hard now for us with the patients is to temper expectation. We turn negative off. If I fix your parking brake, I don't know where you want to drive in your car. You still got to turn it on, get some gas, get a map, and figure out where you want to go. I can't help you with that. It's not my job. I will fix the brake. Rest is up to you. There are a lot of patients, when you think you've been sick a long time, that you imagine you're going to have a new life. And unfortunately, I think we return you to who you are with a 5-year delay or a 10-year delay. And your resourcefulness, your environment, your family, who you actually intrinsically are, will have a big bearing on how you use a brain that has capacity to do what you want to do. And that's the job of clinicians. And so, the partnership between the science and the clinicians, my, delusion many years ago is, neurologists, we'd figure it out. We'd have the wiring. We'd get the basic scientists. We'd work the whole thing out, and it would be very straightforward. It's never straightforward because we always keep changing. People change. You just need to have a substrate that allows you to change. And, I am very convinced. I believe depression is being stuck. We unstick you. And so our job now is to figure out why you're stuck and how you get stuck. But that then once you do this early reset, you have plasticity. And then there continues to be learning over time. And the patient after patient has ways in which they describe this. This woman made us a card, and just kind of realizes that, most of these people's lives is in shambles, but they're ready to work at it in a way that they couldn't when they were sick. And I think our job scientifically, we got to optimize the surgery, we got to do the basics, but we've got to develop strategies that actually consider the biology, which means that the biology is really at the core. And then we hand it off. So I think it gets back to the theme of human disease mapping, which is about patient to translation to population. And it isn't just translation to patient to the population. It's constantly bi-directional arrows, tri-directional arrows, and that everybody finds their place to where they've always got a step with one of the other players. And I'll stop there.